Hello Health on LAE is presented by the Oxner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Oxner Health System, and Humana to bring Oxner's Hello Health weekly education and information series to television. Tonight we're going to be talking about weight loss and the role surgery and a new non-invasive procedure can play in losing weight and keeping it off. Our guest is Dr. William Richardson. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200. That's 504-866-3200. Or you can send us questions by email at hhquestions@wlae.com. We'll ask you to hold off on the phone calls for now. You can send the email questions straight away. Well, Dr. Richardson received his medical degree from the Harvard University Medical School. He completed his internship and residency at Massachusetts General Hospital and a fellowship in laparoscopic surgery at Emory University Hospital in Atlanta. Dr. Richardson is board certified by the American Board of Surgery, and it is our pleasure to welcome Dr. William Richardson back to Hello Health. Good to have you with us on the program.
Thank you for having me, Tom.
Yeah, you're very welcome. It's been a couple of years, and since then, some personal news to share, right? And in the medical field.
Exactly. Yeah, my son just became a general surgery resident at the University of California in San Francisco, so we're very proud of him.
Good. Good for you and good for him. Congratulations, doctor. Well, tonight we're talking about weight loss, and we'll talk about dieting and exercise and the usual things, but we'll also be talking about surgery, the more traditional ones that have been around for a while, and a new one involving a balloon, and Dr. Richardson will be giving us updates on all of these. The first update's an important one, and that's really the characterization of obesity. American Medicine Association redefining it as a disease, right?
That's right. So as it turns out, people don't really have control, or most people don't have control over their weight. Certainly some do, but most of us don't. And for most of us, we gain a little bit of weight every year without any way to control that at all. Certainly, it's costly being obese in terms of medical problems and purchasing your medicines. But there are also other things that help keep us obese. We come from families that are obese and so on. There are hormones in our body that tell us what weight we should be and keep us at that weight. There are things that make it difficult to control our weight, like environmental factors. It's hard for us to buy and produce the food that we ought to be making for ourselves every day. And there are metabolic differences between us. Some people can just eat more than others. What most people don't understand is that our weight is based totally on how many calories we burn in a day and how many calories we eat in a day. And if we are taking in more calories than we're burning up, we are going to gain weight. And it's very, very difficult, if not impossible, for most of us to control that.
And most people put on weight here and there and then lose it and then put it back on. But when we're talking about obesity, we're talking about what specifically? Not just people who are a little overweight, right?
We're talking about people with BMIs of 30 and over largely. That's a height-weight ratio that we have. Normal is 20 to 25, overweight is 25 to 30, and obese and morbidly obese is above 30.
And this can manifest itself in being overweight by 50 to 100 pounds, something like that.
That's correct.
In a general sense. So patients diagnosed with obesity are likely to have other issues, and in some cases serious ones, maybe even die from them. What are some of these other diseases and issues they would have?
There are many medical problems that increase risk of being obese, such as heart disease, diabetes, high blood pressure, high cholesterol. People are more likely to get strokes, cancer, and then if you have arthritis, you can't exercise it off as easily. Sleep apnea is where people are snoring a lot at night and not sleeping well. They might be very sleepy during the day, and it can, if it's not treated, lead very severe forms of heart disease. So all of these things can work against an obese individual being able to live either a normal life or certainly not living to their normal length of life.
Why do you think it took so long for the AMA to come around to the conclusion that it's a disease? Because for so many of us, for so long, we've thought, well, these are just people who can't control their own eating or don't have the self-control to be able to exercise or to not eat what they're supposed to be eating or just to say stop.
I think it's a common misconception that we have control over what we can eat. I think most people believe that they can stop eating if they wanted to, but the fact is that we really can't. Our brain has a set point. Now certainly... And
those are different set points for every person, right?
Absolutely. There are certainly some people who are, you look at a lot of people who are thin, they are able to control their weight and able to eat the right amount every day. But for most of us, it's really very, very difficult and a struggle to try and maintain our weights.
Many approaches to weight loss, and in almost everything we talk about on this program, we always start with a conservative approach. So certainly before we would get to any surgeries, we're going to look at things like exercise and diet, when those things can be controlled, and then medications as a go-between. So let's kind of run down the various options for weight loss.
Sure. Well, certainly diet and exercise is the mainstay. And even if we try any other therapies for weight loss, it's important to try and control as much as possible, sticking to a reasonable diet and getting some exercise. Even if we were to move on to a further treatment, that's going to be important for a lifelong, keeping the weight, to a reasonable level. Some people are going to be able to lose weight with diet and exercise, and therefore shouldn't go on to other therapies because all of them have more risk than just doing diet and exercise. And then after that, we would try the medications. There are a good number of medications out there now. Some of them are very, very expensive, but what they try to do is control, the better ones are trying to control the hormones in the body to try and decrease the amount that you want to eat through hormonal control in the brain. That would be the next step, and we do get moderate amounts of weight loss with the diet pills. Then the surgery is a way to lose more weight and keep it off. So it's a more serious and a bigger thing to undergo the surgery. And then currently the latest thing is the balloon, which is sort of an intermediary procedure between the medications and surgery.
All right. We're going to show you what that balloon surgery looks like shortly, but first the doctors brought along 2 films to show us what the more traditional surgeries look like, starting with the gastric bypass, right?
Right.
So let's take a look at that first, and then we'll talk about it in just a moment. Here's the gastric bypass surgery.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into 2 sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
Of the surgeries we're talking about tonight, this is the gastric bypass surgery. This is the more aggressive of the three, right?
Well, this, in my opinion, really is the gold standard to which all the other procedures are going to be compared to. It has, it's the one we know the most about. It's the one that we've been doing for the longest period of time in the United States.
For decades, right?
Yeah, for decades,
Yeah.
since the mid-60s, actually.
Yeah.
And then it has the most weight loss of most of the most major procedures that we do in the United States. It has the best for the medical problems associated with obesity of the most common procedures done in the United States, and but it also is a more complicated procedure with a little higher risk.
Okay. So how long does this procedure last, and what are the risks associated with it?
Well, it takes us about an hour to do this procedure. Most people go home the next day. We have people on a liquid diet for a week, followed by a pureed diet, 2 weeks, followed by a pureed diet for 2 weeks, and then a soft diet for 2 weeks. And we ask people to be light duty for 6 weeks, but as soon as they're comfortable, we want them to start a walking program or something like that. Although there are major risks to it, it actually is as risky as getting your gallbladder out these days. That's how safe we've been able to make it.
Okay, so that's the first surgery. What's the second one we're going to see?
The next surgery we're going to see is called the sleeve gastrectomy. It is a much less complicated procedure. It has a lower risk to it, but also a little bit lower benefit in terms of weight loss, although much more weight loss than you might get with anything else that we can try.
Okay.
It's the most common procedure also currently performed in the United States.
Very good. Our same narrator will take us through the sleeve surgery.
The sleeve gastrectomy is a restrictive procedure, which limits the amount of food you can eat by reducing the size of your stomach. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form, so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
My TV production crew is going to appreciate this. So when we're running cable for an event, if you run cable from the truck to the camera, which may be all the way in center field, it's called a home run, right? There's nothing in between there to get in the way. That's what I'm reminded of when I look at this.
Oh, yes.
It's the same plumbing for the most part, right?
It's the same plumbing. It's a very simple procedure to perform. Again, most people just spend the night in the hospital. We do with the same diet after surgery, same light duty after surgery, but it is a lot less complicated than a gastric bypass. People do tend to lose weight and generally keep it off, but not quite as much as with a gastric bypass. But then it is a safer procedure, so you can weigh those things together. But it is still an invasive procedure, and we are removing part of the stomach.
Before we get to the balloon option, the newer option, how would you determine if one is the gold standard? Why wouldn't you go with that one?
Well, I think this one is that it's more complicated. There is certainly more risk to it, even though the risk is not high, and you have less control over it. So there's something called dumping syndrome that you get with the bypass, and if about 3 out of 4 people get it, and it means that if you eat certain foods, you're going to get actual stomach pain from those foods. generally it's to the foods we want you to stop eating anyway.
Fatty foods, those sorts of things?
Fatty foods, carbohydrates, and things like that. So it will help you, if you get it, stay away from those foods. But at the same time, you won't be able to eat them as easily as you would with a sleeve gastrectomy because you won't get away with it.
So let's say I was a patient coming in. You're going to help me. Ultimately, it's up to me, right, to make the decision?
That's correct. Unless there's a contraindication to a procedure, and that's rarely the case, I would leave it up to you to make a decision what you want it to do with your body.
So how often do you hear this? Doctor, if it were you, which one would you have? Or if you were doing this on your mother or father, or which one would you have?
Well, I've heard that all the time.
And how do you walk people through that?
Well, you can help guide people, but you have to let them know that it does depend on how much risk you're willing to take. So if you're willing to take a little more risk, the gastric bypass would be okay, but it does give you a little bit more reward too. If you think you need the dumping syndrome because you really like eating sugary and fatty things, then the bypass may be a better choice. So there are some things like that. If you have diabetes, the gastric bypass may be a better choice because it's more likely that will resolve.
All right. Well, still to come, the balloon procedure, a newer one. We're going to be talking about that in a moment. But first, Dr. Richardson wants to talk about the team approach, something we often talk about on this program. So it's not just the surgeon involved, a lot of prep work on the front end, and then a lot of counseling on the back end. So let's talk about the team you're working with.
Yeah, I think that's very important. So weight loss is not just to do surgery and see you later kind of thing. It really requires looking at it from a number of ways to make sure that it sticks and that people continue to keep up their good habits. So we have 2 surgeons in our program, we have 2 physician's assistants, we have 3 coordinators, we have 3 dietitians, we have a financial coordinator because many of these procedures are not covered by insurance. We have psychological support specialists, we have support group once a month, and then we do have physical activity and exercise specialists who work with us too, largely through Elmwood.
Okay. And yes, so the important part is once you've had the surgery, there are restrictions in the area of diet and exercise. So how important is it that people follow that regimen?
Well, in the first year, it's very hard to eat too much because you just feel too full. So you have to learn from that first year how you're going to behave for the rest of your life. And if you keep trying to stretch out your stomach, you eventually will be able to do it. So we have to try and keep that food down, to listen to your body, to know when you're full. I've had patients tell me that it was after surgery, it was the first time they felt full in their lives.
They could have just kept eating and eating and eating.
Yeah.
But these are I guess the point you're going to make on the front end of any of these surgeries, even before you agree to do them, these are life-changing. Life-changing and life-saving.
They're certainly life-saving in a lot of cases, and they are tools. So you've got to remember it's a tool, and you do have to do your part.
What does a diet look, again, not your area of expertise, because you've got dietitians working with you, but certainly part of the team, and you understand this. What does a diet look like for a weight loss patient?
Well, what we want to try and do is have people break up their meals into several small meals so that they don't get too hungry at any specific point. We want people to eat more protein and less of the other things that they've gotten used to eating over the years, their bad habits. So, for instance, breakfast of a protein bar or something like that, a skim milk latte kind of thing, and then a snack before lunch with maybe a boiled egg or a small amount of fruit, and then a lunch that's going to be light and small. So our plates are generally bigger than they should be. We have to think about, and you can actually purchase portion plates to help you with portions.
We could all learn from the French in this area.
That's exactly right. A small amount of chicken salad, and then some vegetables that are cut up, another protein shake for a snack. Thinking about more grilled foods than fried foods at dinner with more vegetables, and then maybe a yogurt later on. So you want to have small meals to keep you full all day long. Make sure they're very high in foods that are good for you. Get used to the taste of vegetables. We've sort of lost our desire to eat fresh vegetables because we just aren't used to having that flavor in our mouths. We're used to covering them with something. And then getting used to some grilled, low-fat meats like fish and chicken.
All right. Well, this is New Orleans, and I don't see crawfish on there anywhere. I don't see burgers on the grill or steak. Is there any wiggle room in there for the things we love and enjoy in moderation?
Well, in terms of gaining weight or trying to maintain weight or trying to lose weight, you're really looking at a total number of calories over a whole year. So if you are, and you do have to treat yourself once in a while, so as long as you treat yourself but make sure that you are maintaining your calories elsewhere, you can certainly do that. So, but in order for trying to keep your weight down, you need to think about your total amount of calories in a year or in a day. So a 50-year-old, the average 50-year-old woman needs between 1,000 and 1,600 calories in a day. In a man, a little bit closer to 2,000, but it does depend on how much exercise that person is getting, because a lot of us are fairly sedentary. On our phones, we've got the step apps, and we can see whether or not we're really getting, 10,000 steps in a day, which is what a reasonable aim. But most of us have learned how not to do any activity during a day. We are driving right up to the front of the grocery store, for instance. We're not getting a walk in and things like that.
Sitting in front of our computer as opposed to sending an email for someone who works just down the hall rather than actually walking to go talk to somebody.
We've learned how to become more and more sedentary, so we have to sort of change that direction a good bit. Also, if you have that hamburger during the day, a large hamburger is close to 1,000 calories, and for a woman, that's 2/3 or so of how many calories they're supposed to have in. It could be all of the calories they're supposed to have in a whole day. And for a man, it might be half those calories. So you've got to be very careful what kinds of foods you eat during the day and start learning to eat lower calorie foods. Now, if you were to have a low-fat, small patty hamburger alone and you weren't having all the stuff that we're used to having on it, well, that's a different matter. That's closer to 260 calories. But you've got to be careful about what you do on the side of that. You can't be having the French fries. You might not have a roll and so on. So we do want to try and get in the protein first and getting in the habit of looking up what's in our food, how many calories there are and so on in our food, how much fat there is, how much protein. And you can look that up on the internet in terms of vegetables and things. Many of the things you eat in restaurants, you can find calories in the internet. But we really want to work on eating the protein first, staying on a low-fat, low-calorie diet, trying to work on decreasing our portion size, again, by taking in more meals in a day so we're not too hungry at one time, and also drinking a lot of water. That can help keep us full or two during the day.
I don't see sodium addressed on there at all. Is that something we should talk about?
Sodium is a good thing to talk about. It's very important for not increasing our blood pressure. People who have high blood pressure or are prone to high blood pressure are going to get worse with sodium. If you are prone to high blood pressure, then you've got to be careful about your sodium intake.
Okay. So let's move to the balloon procedure now, if we could. We're talking about it as a newer procedure. How long have you been doing it?
We've just been doing it for a little under a year now, and it has been around for years, and it was FDA approved in the United States a number of years ago, but there were a number of complications with that old balloon, and it was taken off the market in the United States for many years. Recently, 2 balloon companies have been FDA approved. The one that we're using at the Ochsner, the Orbera balloon, and also the Reshape balloon is the other FDA approved balloon currently in use in the United States. It's the Orbera balloon is a simple one balloon. It's almost like one that you would blow up at home, except it's a lot thicker so it won't break. But we just fill it up with salt water, basically. It fills 1/3 of the stomach, so people generally feel full, and then after you eat a small amount, you'll feel really full. So it helps you stick to a diet by not allowing you as easily to eat as much.
Is the balloon for all patients?
I don't know that it's for everybody. For one thing, it's only in the body for 6 months. We have to remove it at 6 months. So it's something that can give you a jump start on a diet. If you need to lose 20 or 30 pounds and you think that once you've lost that you're going to be good to go and either continue with that weight loss or potentially be able to lose more because now you can exercise better and you've trained your body to eat better, I think it's perfect for that kind of patient. It's only FDA approved for patients 22 and over, up to 65, BMI between 30 and 40, and we do have a medically supervised program that we see people once a month to try and reinforce the good behaviors.
You mentioned that it has to come out after 6 months. Is that because of risk of the balloon bursting?
That's exactly correct. If the balloon bursts, it could cause a bowel obstruction and require emergent surgery. Or a barrel balloon, that's an extremely rare problem. It almost never happens. But if you were to keep it in longer, it potentially could burst. It also could potentially become kind of thickened and hardened enough that it would be hard to remove.
I'm not sure the doctor saw this procedure coming. You mentioned when it was first introduced, there were problems that got pulled off. So now they've got it to the point that they feel like it's safe, and you feel as a surgeon safe enough to be able to perform the procedure. Do you think the day's coming where they'll have, maybe it's not a balloon, maybe it's something else. We call it a balloon, but it inflates and it's there permanently. Do you think that day's coming?
I don't know about that. The stomach is rather sensitive to things on the inside. I think it's better if we can reconstruct things with your normal tissue of your body rather than putting in something like that. There have been things similar to that have been used, but they've also been on a temporary, all thought to be on a temporary basis, and none currently approved.
Okay, we're going to talk about placing the balloon and what the surgery looks like. The doctor will take us through that in just a moment and how it compares to the other two procedures. But first we want to talk about diet pills. How would this compare to diet pills? Again, temporary, right?
Right.
But you would prefer this in dealing with your patients over diet pills or not?
Well, things are continuing to be studied as the balloon is relatively new, and a lot of the diet pills are relatively new, but it does appear that the balloon gives you a more rapid weight loss and more of a weight loss over those 6 months.
Okay. So let's talk about the procedure. You mentioned the other one's going to last about an hour. This less invasive. How's the balloon getting into the body? How are you blowing it up? All those sorts of things.
Well, it's an endoscopic procedure, so people are put to sleep, but not under general anesthesia like we have to do for other surgeries. We put an endoscope down. That's a lighted scope that we can see the inside of the stomach and make sure the stomach is okay.
Coming down
for the
through the
balloon.
throat, right?
Down through the mouth, down through the throat, and into the stomach. And then we place the balloon down the same way, and there's a long tube that's attached to the balloon, and through that tube we inflate it once it's inside the stomach. So it goes down totally deflated, and then it's inflated once it's inside the stomach. Once it's inflated, that little tubing just pops off, and that's the procedure.
Okay. It's saline? Well, saline solution?
Salt water.
Okay. So if the balloon were to burst, no risk?
Well, there would be the risk if it burst that you could get that it would then float down the bowels and cause an obstruction. So there is the fluid
as far
itself
as the saline,
won't
though,
hurt you.
right, okay.
Yeah. But that's extremely unlikely within the 6 months that would ever happen.
Okay, so the balloon therefore would have to be removed, right?
Yes, at the end of 6 months the balloon is removed. We basically go down and pop it and suck out all of the salt water, and then grab it and pull it out, and it comes out back through the mouth. So it's totally non-invasive procedure.
Okay. You mentioned some of the side effects or risks associated with the other surgeries. I guess with any surgery, even procedure, there's going to be some risk, and even so here, right?
Well, the risk of this is incredibly low. It's much lower than the invasive surgeries that I've shown you. It's way less than 1% that anything terrible would happen. On the other hand, your stomach is not really excited about having a balloon in it, particularly in the first week. And these kinds of things, the nausea, the vomiting, and the stomach pain happen within the first week. And we do ask that patients buy a number of medications to help them through the first week to make sure that they tolerate the balloon. After the first week, generally these things are totally tolerable.
We talked about the medical teamwork earlier with the other two procedures in your office. What about with this one?
We do exactly the same thing as we do with our other patients, except that we do work with patients a little bit more intensively. So we try to get them, we try to discuss with them once a month exactly what they're doing to try and keep them on track. We're weighing them once a month, we're seeing them once a month and discussing diets and so on.
Okay. We're not going to talk about specific costs tonight of any of the procedures. We do have a phone number set up just for viewers of this program, so if there's something you'd like to inquire about, we would certainly encourage you to do so. But you did want to point out that none of these procedures, for the most part, are covered by insurance, any of the procedures we've talked about tonight, correct?
Although weight loss surgery is covered by some insurances in the state of Louisiana, most insurance plans do not cover weight loss surgery. The balloon is not covered at all by any of the insurance plans currently.
Okay. And again, we'll have a phone number for viewers of our program who are interested in learning more about the costs with these surgeries. I want to invite our viewers to call us right now with your questions about weight loss surgery and weight loss in general and the balloon procedure we've been talking about tonight. Our phone number is 504-866-3200. That's 866-3200. Or you can email questions to us at hhquestions@wlae.com. However, before we get to those questions, we do want to do two things. Let's first review the balloon procedure that we've talked about. Take that kind of step by step. Who is it right for, and how does it compare to the other two surgeries?
Well, again, it's certain age groups that we're looking for, so 22 to 65, a BMI between 30 and 40, whereas the weight loss surgery, the BMI starts at 35. And so it's sort of an interim kind of weight class that we're using the balloon on. It is a non-surgical procedure. It's a very short thing to put it in, and then removing it at 6 months is a very simple procedure. It's a very, very low risk. It helps you feel full because it fills the stomach, so that if you eat a little bit on top of that, you're going to feel full.
And you've been doing it now for a couple of years. What are your patients telling you?
Well, we've actually had very good weight loss with it, relatively speaking, 20 to 30 pounds on the average patient.
Terrific.
Yeah.
And for those who may just joining us halfway through the program, let's talk about the other areas, other ways to lose weight, and what we've started our program with.
Well, certainly diet and exercise that's the mainstay of trying to get somebody to lose weight. And for the most part, even when we do these procedures, we're doing the best we can to try and keep them on at least a reasonable diet. It is easier with these tools, any of them, the balloon or the surgery, to maintain a regular diet. But there are medications, there are newer medications that are changing the hormone structure in our brains to try and get us to lose weight. Generally, it's more modest amounts of weights we're able to get patients to lose, but we can really help crack down on people's cravings with the medications. And then surgery is the mainstay of treatment once people are what we call morbidly obese, in the more severe obese categories. And the balloon is sort of a middle procedure.
And the big view, the thing we started with, the overarching point we want to make across tonight is the medical community now looking at obesity as a disease rather than just people not having the willpower to exercise or to stop eating. Well, we're ready to take your calls now. Again, our phone number is 504-866-3200. There it is, 866-3200. And there's our email address, hhquestions@wlae.com. Our guest is Dr. William Richardson, and we're back with your questions in a moment. This is Hello Health. And welcome back to Hello Health. I'm Tom Bagwell. Good to have you with us. Tonight we're talking about weight loss surgery and a new balloon procedure with Dr. William Richardson. And now your questions. Let's go to line one. Rebecca is calling us from River Ridge this evening. Rebecca, you're our first caller on Hello Health.
Hi, thank you. I'm 45 years old. I had Roux-en-Y gastric bypass back in 2001 and was successful, lost 130 pounds. I've probably gained back 30-ish, 40 maybe since then. Is the balloon something that would be appropriate for someone who's already had gastric bypass? And if not, what are your conditions for considering a revision?
That's a very good question. The balloon is contraindicated in any patients that have had prior stomach surgery because we're so afraid that the balloon is going to erode through wherever prior surgery has been done on the stomach itself. So if your stomach has had an operation, it's contraindicated. Certainly regaining 30 pounds is not bad after a gastric bypass. Losing 100 pounds and regaining 30 is not bad, and I know from talking to all my patients how hard it is to maintain the weight loss as the years go by. We do revisional surgery on gastric bypasses if there's something that seems to be possible to do, such as making the pouch smaller or making the hole between the stomach and the small bowel smaller is possible if on an endoscopy those things are dilated. Sometimes they're actually not that dilated and people still are able to regain their weight, so that has to be checked. The procedures that we do for that, the ones that seem to, in my opinion, to offer the most weight loss are to do it laparoscopically again. There are procedures to do it from within the stomach using an endoscope, but it seems to me that people don't lose that much weight with those procedures. They do lose a little, but I think people lose a little bit better when we do it laparoscopically. The problem with doing it laparoscopically is there is a much higher complication rate when we do that secondary surgery than when we do it the first time. And because of that, we work a lot harder to try and get people back on track through other means, such as medications, working with our dietitians, and so on. I think that's a very good thing to use medications for, which are much less risky than trying to do a redo procedure.
Rebecca, thank you so much for your question, and congratulations. As you pointed out, losing 70%, keeping 70% of the weight off from where she was.
Exactly right. At 70% excess body weight, 70 pounds really is an excellent thing to do.
Yeah, good for you, Rebecca, and thank you for your call. You mentioned the additional complications, or at least risk, from a second surgery. Take us through that. Why would that be the case?
Well, there's always, whenever we cut bowel, there's always a risk of that area leaking. That's the one that we really worry about when we redo it again. There are multiple papers that have shown that that risk is goes from close to 0% to about 5% on a redo surgery.
So again, a small risk, but a risk nonetheless.
Yes, absolutely.
Yeah. Okay. Thank you, Rebecca, for your call. Let's go to line 2. Rose calling us from Booty this evening. Rose, welcome. You're on with Dr. Richardson.
Yes, I was calling about the sleeve surgery to see exactly how the sleeve surgery works.
Okay. Well, that's a very good question. So we have receptors in our stomach that tell us that whether or not we feel full, and they're stretch receptors. So when you eat, you're stretching out that top part of the stomach, and the receptors tell your brain that you're full. Because that area is so much smaller, that area gets stretched out very quickly after the onset of eating just a few bites. So that's the first thing. Also, there's some hormonal changes in our bodies with both the gastric bypass to a much more stronger degree, but also somewhat with the sleeve gastrectomy, where people feel just a little bit fuller in general, particularly the first year after surgery. So it's those two mechanisms that really work together to help people lose weight.
Rose, thank you very much for your question tonight. We appreciate it. Our phone number is 504-866-3200. That's 504-866-3200. We do have some phone lines open now. And there's our email address at the bottom of our screen, hhquestions@wlae.com. You can send us questions by email too. Well, doctor, here's for our first email question of the night. Can a person with a hiatal hernia, GERD, and diverticulitis be a good candidate for weight loss surgery? And maybe we should take each of those separately and then maybe together. I don't know. So let's start with hiatal hernia.
Well, it is somewhat of a complex question. So the hiatal hernia, it can be repaired during the surgery. So that's not a big deal, really. It adds a little bit of complexity to the surgery because we've got to repair the hiatal hernia. The hiatal hernia is where the stomach is pulled up into the chest a little bit. And actually 1 in 5 people has one, a small one usually. So we're always looking for that during the surgery to repair if it is there. There's a smaller percentage of people who have a much larger one. Again, we would just fix that during the surgery as part of the procedure itself. So the hiatal hernia is not a problem. We do see problems though with people with severe reflux disease. Severe reflux disease and a sleeve gastrectomy sometimes is not a good combination. Occasionally people actually get worse reflux disease after a sleeve gastrectomy. A gastric bypass actually cures reflux disease in almost everybody who has reflux disease. So those two things are something that we would discuss with a patient about. In terms of diverticulitis, having it an ongoing, and so diverticulitis implies that people not only have diverticula, but also ongoing infection. Diverticula are usually around the distal part of the large bowel or colon, and generally we don't do elective surgery on somebody that has an ongoing infection. So having diverticula would be okay, but if you have an ongoing infection, what we call diverticulitis, we'd have to wait till that was over.
If one of these surgeries is almost a guarantee for serious acid reflux, is this ever an option just for acid reflux, not necessarily weight loss?
Well, so people who are morbidly obese with acid reflux would do very well. So, you know, we have so many people who don't have insurance coverage for weight loss. So we get patients who come to me with severe reflux who want to do something about the reflux. They might want to do something about the weight loss surgery, but they can't afford it. So they're coming to me for reflux, and so we do an anti-reflux surgery, but it's not going to get them to lose weight. But they would do better, they'd have a better chance of improving their reflux if we did the gastric bypass.
So it's a 2-for-1.
It would be a 2-for-1 if their insurance would allow it.
All right. Our phone number is 5, and do you ever have anybody saying, doctor, you're in there anyway, can you, no one's ever, I'm just talking about what really happens in life, right? Do you ever have anybody say, hey, while you're in there, can you do it? I mean, obviously you've got to stick to
well, the problem is if the insurance company looked at the procedure, then they would not pay for it.
That's right. All right, our phone number again is 504-866-3200, 866-3200. We do have phone lines open. Let's go to line 1. Mary is calling us from Metairie this evening. Mary, you're on with Dr. Bill Richardson. Go right ahead.
Tom, thank you so much for taking my call. It's been a great show. I have two questions, actually. The first is, can you explain more about the weight loss specialist physician, and is that required as part of the process? And then also, does insurance pay for that visit with that bariatric physician?
That's a great question. We talked about, does insurance cover the surgery itself, but what about the team approach?
So the team approach is covered by insurances that cover weight loss surgery. So in general, people come in for a consult where we find out what all their medical problems are and work on it from that standpoint, and then we set them up with a program that will head them towards surgery. So if we're going towards surgery, people are required to see a nutritionist because we need to teach them about diet and what the diet is like after the surgery. We get psychological clearance on all patients, and if patients have very serious medical problems, we'll talk to their regular doctors to make sure that they are healthy enough for surgery, which is usually the case for most patients. So that's different, though, than we do have a medical weight loss doctor, what we call a bariatrician, who gives people medications for weight loss. That's more often covered by insurance plans than the surgery. So if somebody is not interested in the surgery but interested in weight loss medications, we have a bariatrician who does cover that service. But if you're coming in for a consult for surgery and you have insurance coverage for weight loss surgery, that will be covered.
All right. Mary, thank you for the kind words, and good programs start with good guests who are educated and passionate about their field. So I thank Dr. Richardson and all of our guests here on Hello Health for making it that way. Doctor, here's our next email question. And we do have phone lines open, by the way, at 504-866-3200. That's 866-3200. Here's the question, Doctor. Is someone with a body mass index, BMI, of 40, but with no other diseases associated with obesity, candidates for surgery? This is from Jerry. Jerry, thank you for your question.
Yes, absolutely. If you have a BMI of 40 and no other medical conditions, you are a candidate for surgery. Now, according to the National Institute of Health, they made up the definitions in the 90s that we still use today. Now, people's insurance plans may have other criteria. The insurance plans can make it much more strict and difficult to get surgery than what the National Institute of Health and most of us surgeons agree to.
Okay. This question hasn't come up yet, but I'm going to ask it anyway. If the legal definition, or not legal definition, but the medical definition of obesity is changed to a disease, right? Do you think the insurance companies are going to catch up? Because we started off by talking about this disease causing all these other complications, and many of them serious ones. Do you think the insurance companies will come around? You would think in the long haul, I'm not trying to get political here, but it would be in their best interest to cover these sorts of things.
Well, I think, yeah, it would be in their best interest, because it does appear that they would actually save money, and we would as a country save money in the long term. At least so we know that the cost crossover for somebody with diabetes is around 2 years, and for other people is around 6 years or so is the cost crossover. So over the long term we would save money. The thing is that people change their health plan every 3 years, so the insurance company that pays for your surgery may not actually get that benefit. But if all of the insurance programs in a state were required to cover the weight loss surgery, then they would all get the benefit as long as they didn't leave the state. So I think that's one thing. But I really think that the main problem is that most of us feel that we can personally control it, and therefore we don't demand that we have treatment coverage for weight loss.
Good points all. Again, our phone number 504-866-3200, 866-3200, or send us questions by email, hhquestions@wlae.com. Let's go to line 1. Herb has been holding from Metairie. Herb, welcome. You're on Hello Health with Dr. William Richardson.
Hello?
Herb, are you there?
Yeah, I'm here.
Go right ahead with your question for the doctor.
Okay. I have a bulge in my stomach. I think they call it a hernia. It's about the size of the palm of my hand. And years ago, I had asked a surgeon about it, and he said that if I didn't lose weight, that he could sew me up and it wouldn't matter to come back. And I have kept my weight down, but it keeps coming back. And I thought maybe his answer was wrong, that I should get the surgery to stop the bulge in my stomach. It's right to the above and to the left of my navel.
Mm-hmm. Well, it's interesting. So a hernia is a hole in the muscle wall, and it allows our insides to go in and out of the hole. As it turns out, hernias can be fairly hard to fix and remain fixed, particularly with people who are obese. So we have started to develop criteria where we know there's such a high chance of recurrence that we try to get people to lose weight prior to doing any hernia surgery. So things like smoking is another problem with hernia recurrence and hernia infections, and weight is too. But it really has to be a fairly high weight. If you're having, so the best thing to do, if you meet criteria for surgery and you have a hernia, really the best thing to do is the surgery and fix the hernia at the same time if you're having trouble maintaining your weight.
Herb, thank you for your question and best of luck to you. 504-866-3200 is our number. Let's go to line 2 in Houma, where James is holding. James, you're on with Dr. Richardson.
Yes. First of all, gentlemen, thank you for your wonderful program. Dr. Richardson, my daughter had gastric bypass surgery, and she's, has periodic pains and whatever. Can that be reversed?
That's a very good question. There are people who get the gastric bypass who have various pains, and we look very hard at those patients to try and figure out what is causing those pains. Not infrequently, we go back to the operating room to take a look at the bypass and see if there's a problem that can be fixed to get rid of those pains. There are a number of things that can cause those pains that require surgical correction, and they are kind of probably trickier than we can discuss at this program, and with the time we have, but there are a number of little things that we can do that sometimes will make somebody feel better.
So in what percentage of cases are you having to go back and do some sort of revision, or how many people are experiencing pain from surgery?
It's probably in the 1% to 2% range, so it's a very small amount that people will have a long-term pain. One of the more common problems would be, say, an ulcer or something like that, and frequently we can just treat that with medication. Sometimes it's people just eating the wrong things. If they get the dumping where they eat, after the gastric bypass, 3 out of 4 people do get dumping where they get pain after they eat the wrong things. And sometimes it's a reversion, they're changing back to a diet and don't realize it. that's a bad diet for them. So there are some things that we can do without surgery, and then other times there are little things that we've got to sort of fix up.
All right. Let's go back to our phone lines. 504-866-3200 is our number. Drawvan calling us from Destrehan this evening. You're on line 3 and you're on Hello Health.
Hey, how you doing?
Well.
I'm calling, I have a question in regards to, I've had actually 4 surgeries now for weight loss. I started off with a gastric band. The gastric band slipped. They removed it. They did the gastric sleeve. The doctor that performed that procedure actually cut my stomach too large and decided to go back in and do a gastric bypass. Well, after having that surgery, I went back and had a revision because I never, ever, since having the surgery, ever felt full. So like where the stoma is, the food doesn't stay retained in that spot and just constantly goes through. So I go and have this revision surgery, and I'm having the same exact problems that I had from the first surgery. And I just can't understand how, if I have this cut smaller, how am I still having this problem even after a second surgery?
Sounds frustrated, and probably for good reason.
Yeah, that's unfortunately, it is not, the surgery is not perfect. It is certainly only a tool, and it can only do so much. So that we know, for instance, with the gastric bypass, that 70% of people or so will be able to keep off their weight for a long term. But that's not 100%. That's 7 out of 10 people, and 3 people will not do well. Of those 3 people that don't do well, we can consider revisional surgery, but it's not as good as the first time surgery. So I can understand the frustration at having 4 surgeries, but I can tell you that it does happen from time to time. The surgery just isn't perfect.
Drawvan, we appreciate your call tonight, and best of luck to you. Let's see, could you please repeat the names of the new weight management medications? This is from Karen. I think you may have mentioned those earlier.
Well, I'm not the bariatrician in the practice, but one of them is Contrave, and there are a bunch of others. There is one of them that's $1,000 a month.
Okay, so expensive.
Some of them can be expensive. Other ones you can get coupons for where they're closer to $100 a month, but they're not. Most of the better ones are not inexpensive.
Okay, and we were talking earlier about how you got to allowing the stomach to retain 10% of its capacity. Why not 50? How did we end up with the 10% number rather than 50% of the number?
Well, when we do the surgery, it's really that we have to leave, it's not really a percentage. People's stomachs are different sizes. The fact is we have to leave enough behind that you can eat. So that the amount that we leave behind is about the same on everybody. The amount that we remove might be a little bit different depending on how the stomach is shaped.
Gotcha. And that 10% capacity that's left, does that mean we're only going to be able to, real simple here, does that mean we're only going to be able to eat about 10% of what we were eating before?
Well, initially it's probably a little bit less than that. Initially I think people feel full after eating, or the most, outside of the gentleman who is having a hard time feeling full. Initially, you generally feel very, very full after eating a tiny amount. So after a gastric bypass, for instance, it could be less than the size of an egg even, which is less than 10% of what most people are eating in a meal. But it is a little bit different for everybody.
Okay. And our final email of the evening, doctor, have you ever had long-term complications from the Obera procedure? This is from Sandra. Sandra, thank you for your question. Maybe tough to, I'll let you answer, but it may be tough because you've only been doing it for a period of time.
I have not had any long-term complications. Certainly it would be possible, but it really is, anything is possible, but it really is a very safe procedure.
All right. Well, when most of our guests come here, there's at least 1 or 2 points they want to hammer home to make sure that our viewers got. So in this case, what are you hoping people walked away with tonight?
Well, I do hope they understand that any of the procedures that we do for surgery is a tool to lose weight, that people still have to work a little bit on their own to keep up their weight loss with a reasonable diet and exercise. Anybody who's interested in we all need to think about what we're going to do for being overweight, if we want to live as long as possible and as healthy as possible. We can start today to change our diets and work on our diets. That doesn't necessarily require surgery to do. So surgery is, though, the mainstay of treatment for people who are seriously obese, and I think the balloon is a great interim procedure.
All right. We do have one more caller on hold that we're going to try to get to. Sneak in one more caller here, doctor, who's been waiting patiently. Don't have your name on our screen, but we'll let you go. It looks like we've lost our caller. So we encourage you to call back, and I want to pass along this number to everyone on our program. We have a special number just set up for viewers of this program, as I thank Dr. Richardson for the education and information and passion he's shown tonight. Thank you, Dr. Richardson.
Thank you, Tom.
And best of luck to your
it.
son, following in Dad's footsteps.
Thank you very much.
Yeah. So to make an appointment with any Ochsner physician, including tonight's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at this number. Again, it's set up just for viewers of this program, 504-842-5669. That's 504-842-5669. As a reminder, you can rewatch tonight's presentation or any of our Hello Health programs on WLAE's website at WLAE.com, or Ochsner's website has lots of the programs too at ochsner.org. Our thanks again to tonight's guest, Dr. Bill Richardson. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of our program, Hello Health, and this station, WLAE. Good night.
Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.